Hi, I'm Corinne. I'm a medical oncologist working out of BC Cancer Vancouver, and I will be sharing with you today or reviewing with you the management of metastatic prostate cancer. The Prostate Cancer Supportive Care Program was implemented in January 2013, and it is funded primarily by philanthropic donations, which we are grateful for. The Prostate Cancer Supportive Care Program is a comprehensive cancer survivorship program designed to help both patients and their partners across the entire disease trajectory, from the time of initial diagnosis and onwards. It is composed of 8 modules, which you can see in the slide here, and patients can partake in any of these depending on where they are at their disease journey. The focus of the program is to assist with physical and mental health of patients diagnosed with prostate cancer. The educational objectives of the talk today is to learn about prostate cancer disease states and terms such as castration-sensitive disease and castration-resistant disease, understand the disease characteristics and natural history of metastatic prostate cancer, become familiar with different treatments of metastatic prostate cancer and the types of therapy available and their side effects, and learn how to be prepared for treatment. So what you see in the slide here is a diagram of the pelvis. The prostate is a gland that is situated below the bladder and encases the urethra, and this is where the cancer originates from. It can then metastasize to different organs, and you can see here in the picture the different organs that could potentially be involved with the disease. The most common organs to be where we may find metastatic prostate cancer is in lymph nodes and bones, and it is very rare to find for the disease to disseminate to the lungs, liver, or brain. In order to diagnose prostate cancer, we use multiple modalities. The first is a biopsy. And when the biopsy is reported by the pathologists, they usually detail the Gleason score, which you may have heard of. This suggests how well differentiated the cancer is and correlates with outcome among patients with localized disease. We then use a blood marker, which is called PSA. The PSA level correlates with the disease activity. A rising PSA indicates that the disease is progressing, whereas a declining PSA suggests that the disease is regressing and is well under control. We then use imaging studies, specifically CT and bone scan, that can detect metastatic disease in the different organs. Prostate cancer is unique in the fact that it is primarily driven by testosterone, the main male hormone. This hormone is produced in the testes, and the first step in controlling prostate cancer is deprivation of testosterone. This can be done either surgically by removal of the testes or medically with an injection that is given once every few months. And this androgen deprivation therapy or testosterone deprivation therapy is the backbone of treatment of metastatic prostate cancer. It is the first step in the treatment, and it continues throughout the disease trajectory. Prolonged treatment with androgen deprivation therapy can result in multiple side effects. And if you are experiencing any of these, you are welcome to join Module 4 that discusses ADT therapy and side effect management. Now let's dive into 2 important terms in the treatment paradigm of prostate cancer, and these are castration-sensitive and castration-resistant disease. Now, in order to explain these 2 terms, what you see before you is a schematic diagram of the PSA and testosterone of a patient with metastatic prostate cancer. Now, initially, the patient has rising PSA with normal level testosterone. Once the patient is diagnosed, at this time point, he is started on androgen deprivation therapy, and you can see that in response to the androgen deprivation therapy, both the testosterone and the PSA are going down. Now, the testosterone remains low throughout the treatment course, whereas at this time point, the PSA starts to rise. Now, this time period where the testosterone is low and the PSA is going down is termed castration-sensitive disease. And this is the first phase of metastatic prostate cancer. Unfortunately, over time, the disease finds resistant mechanisms, and while the testosterone remains low, the disease is progressing as seen with the rising PSA. At this time point, the disease is termed castration-resistant. So again, initially, the disease is termed castration-sensitive, and you can see that the term means that the testosterone is low and the disease is well controlled. And later on the disease, when the testosterone remains low but the disease is progressing and the PSA is rising, the disease is termed castration-resistant. Now that we understand the different disease states of metastatic prostate cancer, let's dive into our treatment options. And we divided these options into 4 classes of drugs. And the first one I'll review with you is androgen receptor pathway inhibitors. So as detailed previously, prostate cancer is primarily driven by the male hormones. Now, the primary male hormone is testosterone, and the testosterone is eliminated by the androgen deprivation therapy. But we do know that there is a small amount of other male hormones that remain in the body, even with the androgen deprivation therapy. And this small proportion of male hormones can still continue to drive the disease. The androgen receptor pathway inhibitors all control for that small portion of other male hormones. And they do it either by controlling for their biosynthesis or by blocking the binding of these hormones to the androgen receptor in the prostate cancers. We have 4 such drugs. We have 1 drug that controls for the biosynthesis of these hormones. This drug is called abiraterone. It's an oral drug taken once daily on an empty stomach. It's taken with another drug called prednisone with an intent to control for the potential side effects. The main side effects of this drug is hypertension, high blood pressure, electrolyte imbalance, and liver toxicities. These are 2 abnormalities that you will not feel. We will find them on blood tests, and that is why initially when patients are started on this drug, they need quite frequent blood work. And then finally, this drug can cause peripheral edema, swelling of the legs and hands. This treatment is taken can be given either in the castration-sensitive or castration-resistant state, and it is taken until it is no longer working, so we see clear disease progression, or if there's intolerable side effects. Now, the other group of drugs all block the binding of these hormones to the androgen receptor in the prostate cancer. And we have 3 such drugs. The first is enzalutamide. It's an oral drug taken once daily, either with or without food. There are no concomitant medications that need to be taken with it. And its main side effects are fatigue, cognitive impairment, and it can cause a decrease in seizure threshold, which basically means that patients that are at higher risk for seizures, the drug would increase their risk for seizures. So they would not be given this drug. Just like abiraterone and the other drugs, it is taken until there is clear evidence of progression or if there's intolerable side effects. The next drug is called apalutamide, again an oral drug, and its main side effects are fatigue, instability in falls, hypothyroidism, which is hypofunctioning thyroid gland, which is tested on blood tests, and a skin rash. The skin rash is actually quite common and can happen in up to 25% of the patients. And when we see that skin rash, we sometimes have to hold the treatment to allow recovery from the rash. But interestingly, if we resume treatment after the rash has recovered, it usually does not recur. The indications for apalutamide are either castration-sensitive disease or a non-metastatic prostate cancer, which will not be discussed today. Again, like the other drugs, it is taken until there is clear evidence of progression. And finally, the last drug in this class is called darolutamide. It's taken orally twice a day, and it is right now approved in Canada only in combination with docetaxel, which is a chemotherapy for castration-sensitive disease, or as a single agent in non-metastatic disease, which we will not be discussing today. Of this class of drugs, darolutamide is actually the best tolerated drug. It has minimal side effects, which are mainly fatigue and rarely a skin rash, and it is taken until clear evidence of progression. Now, all these drugs are effective in the treatment of prostate cancer. Throughout the course of disease, you are likely to receive one of these drugs as part of standard of care, and possibly an additional drug if you choose to be in a clinical trial. The choice of which drug to give as standard of care depends on a discussion with your physician and guided by the side effects, potential interactions with your other medications, or your comorbidities. The next class of drugs I'll discuss is chemotherapy. We have two such drugs. They are both given intravenously, and their mechanism of action basically stops the cell cycle, holding any activity of the cancer and hopefully resulting in regression of the prostate cancer. We have two such drugs. The first is called docetaxel. It's given intravenously once every 3 weeks, along with another drug called prednisone. And its main side effects are fatigue, low blood counts, diarrhea, neuropathy, which is damage to the peripheral nerves, which can present as tingling, burning, or numbness to the fingers and toes, hair loss, nail changes, and lacrimation. The docetaxel can be given either in the castration-sensitive state, and for this indication it is given for a total of 6 cycles, or in the castration-resistant state, in which case it would be given for 10 to 12 cycles. The treatment is continued until either progression or until completion of the intended number of cycles. The other chemotherapy is cabazitaxel. It's given intravenously once every 3 weeks, together with prednisone, and the side effect profile is very similar to docetaxel. It is only given in the castration-resistant state after a patient has been exposed to docetaxel for a total of 10 to 12 cycles, as long as the patient is responding. Now, allow me to go into some detail about some of these side effects that are important to acknowledge and know how to manage. The first is fatigue, which can be quite debilitating, although usually self-limiting. However, if it is severe, it could be concerning for other causes rather than the chemotherapy, such as an infection. So in these cases, please contact your most responsible physician to rule out any alternative diagnosis. Now, chemotherapies can cause a decline in blood counts. One of the most important blood counts is the white blood count. And when low, patients may be immunocompromised and more susceptible to infections. In these cases, if there's fever, that would be considered an emergency. And we advise patients while on chemotherapy to seek immediate medical attention at any time point when they should present with fever. The next is diarrhea. It is a relatively uncommon side effect, but can occur. If it is mild diarrhea, it can be controlled with antidiarrheal agents. But if it is severe, so large amounts, more than 3 times a day, accompanied by significant abdominal pain, fever, general deterioration, or risk of dehydration, you must seek immediate medical attention. Peripheral neuropathy can occur with accumulating dose of chemotherapy and will be monitored regularly by your treating physician. Sometimes, if it becomes significant, your treating physician may decide to decrease the dose of chemotherapy or give you a treatment holiday to allow some recovery of the nerve damage. Unfortunately, some of the nerve damage may become chronic and irreversible. Hair loss and nail changes are bothersome, but are temporary and reversible once the treatment is discontinued. And finally, some patients experience lacrimation, which is tearing of the eyes, which can be irritating, but usually recovers once treatment is discontinued. The next class of drugs are radiopharmaceuticals. We have one drug in this class. It's called radium-223. Now, what you can see here on the periodic chart, that radium-223 and calcium are on the same column. And radium is very similar in structure to calcium. As such, it is taken up by the bones just like calcium. Now, radium-223 is a radioisotope of radium that emits alpha radiation. So when we inject radium-223, it is uptaken by the bones, and specifically in areas of high bone turnover, such as bony metastasis. And once taken up by the bones, it emits radiation, causing cell damage and death. So radium-223 is given intravenously once every 4 weeks for a total of 6 cycles. It is indicated for castration-resistant disease and only to patients who have primarily bony disease with no significant disease outside of the bones. It's relatively well tolerated, but can cause low blood counts and diarrhea. It's important to note that PSA is not a good marker for treatment response, and we usually monitor patients who are getting radium-223 clinically to assess for any disease progression symptoms, and we use a different marker of bone disease activity called alkaline phosphatase as well. The last class of drugs I'll discuss is actually not a class of drugs. We just lump them together. It is targeted therapy and clinical trials. The first targeted therapy I want to review is lutetium PSMA. The first targeted therapy I'll be discussing is lutetium PSMA 617. Now, PSMA is a transmembranous protein that is overexpressed on prostate cancer cells, but is rarely found on other tissue, making it a very attractive target for multiple uses in prostate cancer. It was first used for diagnostic purposes. You may have heard of a PET PSMA. A PET PSMA is a CAT scan that uses a small molecule that binds to the PSMA on the prostate cancer. And this small molecule is linked to a radioactive isotope that emits radiation that is read by the scan. A PET PSMA is slightly more sensitive than a CT scan or bone scan to detect disease, but it is still investigational and used only within clinical trials and not available as standard of care in British Columbia. More recently, the PSMA has been used as a therapeutic target. Similarly to the PET PSMA, the lutetium PSMA uses a small molecule that can bind to the transmembranous PSMA. This small molecule is now linked to an isotope of lutetium that can emit beta radiation. Once the small molecule binds to the PSMA, this complex is internalized into the cell where this small molecule is cleaved off and the lutetium emits its radiation, resulting in cancer cell damage and death. Unlike radium-223, this molecule reaches all prostate cancer sites, so it is not bone specific. The lutetium PSMA 617 is given intravenously once every 6 weeks for a total of 6 cycles for as long as the patient is responding and is tolerating the treatment. The treatment is relatively well tolerated, with the main side effects being low blood counts and a dry mouth. This treatment is already Canada Health approved, but is not yet publicly funded in British Columbia. It can be accessed through a clinical trial, if available, or out of pocket. The next targeted therapy I'll discuss is called olaparib. As our body of knowledge grows, we are learning more about cancer. We now know that cancer is driven by genomic mutations. And in British Columbia, for patients with metastatic prostate cancer, we have genetic testing available, both for patients' inheritable DNA, as well as testing of the cancer DNA. And this helps us both in identifying patients who may have inheritable mutations that may predispose them to cancer, but may also have been inherited. This may help identify family members who may be at risk as well. But this genetic testing also helps guide us in treatment. We know that up to 30% of patients with prostate cancer may have potentially targetable DNA alterations. And of these, up to 15% may have alterations in BRCA1, 2, or ATM. Now, these specific mutations, BRCA1, BRCA2, and ATM, may be targeted by a drug called olaparib, which is available for patients with these mutations. Olaparib is an oral drug taken twice daily for as long as the patient is responding and tolerating the side effects. And it is indicated for patients with castration-resistant disease who harbor either BRCA1, BRCA2, or ATM mutations, either as an inheritable mutation or one that evolved within their cancer. Olaparib has very unique side effects. It can cause a decline in blood counts that require regular monitoring of the blood counts, and in some cases, adjustment of the dose. It can cause mucositis. It can cause fatigue, loss of appetite, and it has a very rare side effect which presents as secondary hematological malignancies, which actually means a secondary cancer of the blood. This is exceedingly rare. The benefit of the treatment outweighs the side effect, but it does require regular blood counts. The last treatment option that I'd like to discuss is clinical trials. In oncology, we have many clinical trials that are intended to explore new treatment approaches and look at other aspects of patients' care to improve our care of prostate cancer patients. So why should you consider participating in a clinical trial? I think the most important thing is that it offers you the possibility to get treatments that you may not have access to otherwise. And in BC Cancer, we try to maintain a clinical trial portfolio that offers patients treatments that they would not have access to otherwise at every stage of their disease. It also provides additional attention and support from clinical trial staff. We always aim to give the best care to all of our patients, but because of the resources allocated to clinical trials, there is a little bit more support when you are on a clinical trial. And finally, it's an opportunity to contribute to moving the science forward and help others in the future. In British Columbia, we have a provincial genitourinary biobank, which is a repository of blood samples and clinical data collected from patients with metastatic prostate cancer. It's provided voluntarily by the patients, and it serves as a resource to learn more about the natural history of prostate cancer and identify prognostic and predictive biomarkers of disease and treatment outcomes. If you are living in British Columbia, I encourage you to consider enrolling in this, and you may enroll in any of the BC Cancer sites. So now that we are aware of all the different treatment options, the next question is, how do we sequence these treatment options? What you see here is a schematic diagram of a patient's PSA and testosterone throughout their disease course. Now the patient, as you can see, initially has rising PSA, and normal testosterone, he is considered castration sensitive. And then once the PSA starts rising again, the patient is considered to have castration resistant prostate cancer. Again, we start off with androgen deprivation therapy, which is carried out throughout the disease course, even after the deprivation is insufficient to fully control the disease. Now, what can we add on top of that? So at the castration sensitive state, we can add different treatments that have been shown to improve patients' life expectancy and quality of life. The options are either one of the oral androgen receptor pathway inhibitors, abiraterone, enzalutamide, or apalutamide. We can give chemotherapy in the form of docetaxel or the combination of darolutamide and docetaxel. All of these additions have been shown to prolong life expectancy and improve quality of life when given on top of the androgen deprivation therapy. Unfortunately, they cannot eliminate the disease altogether, and over time, the disease will progress, at which time we would refer to it as first-line castration-resistant disease. And our treatment options at this time point are abiraterone, enzalutamide, or docetaxel. Again, this will likely result in disease control, but over time, the disease will progress and we will carry on to the second line, at which time the treatment options would be radium-223 or chemotherapy in the form of cabazitaxel. And finally, for third line and any further lines of treatment, it really depends on the prior treatment exposure. Once patients are tested for genomic alterations, if they are found to have either BRCA1, BRCA2, or ATA mutations, they may be treated with olaparib at some time point throughout their castration-resistant disease. And you can always consider participation in a clinical trial, and you can discuss that with your treating physician. It's important to understand that the decision regarding the sequencing of treatment, of further lines of treatments after the first line, is really dependent on what you were exposed to prior. Your general well-being, your status, your goals of care, as well as provincial guidelines and treatment availability. So let me share with you a little bit about how to decide what treatment to use and some of the considerations that your treating physician may take into account when making the decision. Your treating physician may look at the volume of your disease, whether you have a lot of disease or very little disease, how fast the cancer is spreading, and how symptomatic, how many symptoms you have from the disease. If it's rapidly progressing or the patient is quite symptomatic, we would want to have a treatment that the patient is likely to respond to faster. We'll consider your other medical problems, and we'll look into any prior therapies you had for prostate cancer. We'll discuss with you the potential side effects, toxicities of the therapy. We'll look into the duration of therapy. Some are ongoing for as long as you are responding, whereas others are given for a limited time period. And we'll talk with you about your own preferences and logistics. So when you meet with your treating physician, it's important to come prepared and to know what to ask about your treatment. It's important to know what the options are and why one treatment was selected over another. It's important to understand what to expect in terms of side effects, how frequently the treatment is given, how long the treatment with the drug will last. It's important to ask what can be done to treat side effects. It's always good to request written material and reviews because it's really hard to retain all the information that was given to you during the meeting. And ask your treating physician who you may contact in between clinic appointments if you have any questions or concerns. Finally, once the treatment plan has been determined, let me share with you how we'll assess your response to treatment. The most important factor is how well you're doing. Every time you see your treating physician, they will ask you about disease-related symptoms, pain management, appetite, urinary symptoms, and then they'll ask you about potential side effects from that specific treatment. That will give your treating physician an indication whether you are responding and tolerating the treatment. Your treating physician will also follow your PSA regularly How frequently the PSA is followed is really dependent on the treatment you're getting, yours and your physician's preferences. We expect your PSA to decline when you are responding to treatment and rise when the disease is progressing. But it's important to note that up to 25% of patients will have an initial rise in PSA even if they are responding to treatment. So unless there is clear evidence of clinical progression, your treating physician will likely carry on with treatment initially, even if they see a PSA rise for at least the first 3 months of treatment. Finally, imaging studies, a CAT scan and a bone scan, can be helpful in monitoring disease progression. But because we have very good markers of disease status in the form of clinical assessment and PSA, we don't need to do regular imaging studies for prostate cancer. Imaging studies are done at the change into a new therapy to provide a baseline, and then otherwise it's done at the physician's discretion. But there is no need to have regular imaging every few months. So now that you know all that I've shared with you, the next question is, so which treatment do you choose? It's important to note that all the treatment options may decrease the risk of death, decrease the risk of progression on scans or by PSA, and improve the quality of life. And the decision is really up to you and your medical provider to be done as an informed discussion. This is a summary of all the drugs that are available in British Columbia as part of standard of care. And you can always ask your treating physician about clinical trials, and don't forget to ask them about genomic testing. Sometimes talking about cancer can feel overwhelming. We recognize that educational sessions can sometimes feel a little overwhelming as well. There can be a lot of information that we are sharing that can have significant meaning for you. While we hope that learning more about prostate cancer and treatment options will ease some of your concerns and worries, we also understand that this information may add to feelings of uncertainty and anxiety. These feelings are normal. Our team is here to help with any questions or concerns you might have after attending this session. We also invite you to consider meeting with our counselor to talk about some of these feelings. Our counseling program offers 6 free sessions that you book with our clinical counselor at any time. This is the program contact details, and please feel free to contact us at any time if you'd like to join any of the modules or have any questions.